Assalamu alaikum. Let's discuss about brain death. Brain death and cardiac death are two legally acceptable definitions of death. What is brain death? Brain death means the heart keeps beating, but there is complete cessation of whole brain activity, including cortex and brainstem, including cortex, which will be present in the form of coma, and the brainstem. There is apnea and cranial nerve areflexia. And cardiac death means the heart stops beating, that is asystole. Okay, so cardiac death means heart stops beating. Irreversible electrical mechanical asystole circulatory arrest. Apnea is universal, requires no formal testing, and confirmed by observation period approximately 5 minutes of the life support. And brain death is brain and brainstem activity ceases, but the heart is still beating. In brain death, the most important thing is this too: absence of brainstem reflex, and then we do the apnea test. Apnea requires formal testing to rule out residual brainstem function. To rule out residual brainstem function. How can we diagnose a patient with brain death? And clinical criteria: known cause, traumatic brain injury, stroke. Evidence is clinical neuroimaging of devastating CNS event, exclusion of confounding conditions, electrolyte abnormalities, exclusion of confounding conditions, electrolyte abnormality, intoxication, paralytics, and core temperature more than 36 degrees Celsius, and systolic blood pressure more than 100 millimeter mercury. Clinical examination is coma, absence of brainstem reflex. What are those brainstem reflex? Pupillary reflex, corneal reflex, oculocephalic or oculovestibular reflex, jaw jerk, cuff reflex, and gag reflex. These are the brainstem reflex. If there is absent brainstem reflex, that means pupillary, corneal, oculocephalic or oculovestibular, jaw jerk, cuff reflex, and gag reflex. Absence, absent brain originating motor responses, absent brain originating movements originating from the spinal cord, deep tendon reflex still may be present. Deep tendon reflex still may be present. Absent brain originating motor response, including decerbate, anticortical posturing, and apnea test. No respiratory response to PaCO2 is more than 60 millimeter of mercury. So if we do first, for diagnosing of the brain death, you need to do you need to see the brainstem reflex. If there is absent brainstem reflex, no pupillary, corneal, oculocephalic, oculovestibular, jaw jerk, cuff, and gag reflex. If there is absent brainstem reflex, then do the apnea test. If after apnea test PaCO2 is more than 60 millimeter of mercury, then you can say that there is brain death. Still heart is beating, but there is brain death. Okay. Diagnosis of brain death: clinical or brain imaging Evidence of devastating cause, absence of confounding factors, sedative metabolic, no evidence of ongoing drug intoxication or poisoning, and core temperature more than 36 and systolic blood pressure more than 100. If it is present, if core temperature is more than 36 and systolic blood pressure is more than 100, if it is present, then do the neurologic examination. So for diagnosing of brain death, first brain imaging, evidence of devastating known cause or absence of confounding factors like patient is not on sedative or not any metabolic abnormalities, no evidence of drug intoxication or poisoning, and core temperature is more than 36 and systolic blood pressure is more than 100 present. Neurological examination, patient is on coma, absent brain originating motor reflex, absent brain originating motor response like flexure or extensor posturing, and absent brainstem reflexes. Absent brainstem reflex, no pupillary light or corneal reflexes, no oculovestibular reflexes, no cold caloric response, dull sigh, no cold caloric response, dull sigh, no cough, no cough or gag reflex, no cough or gag reflex on tracheal suctioning, no cough or gag reflex on tracheal suctioning, and absent routine or sucking reflex, absent routine or sucking reflex, and spinal reflex jerking may be present, like deep tendon reflex may be present. After neurological examination, seeing absent brain originating motor response and absent brainstem reflex, if these responses are present, do the apnea test. If do the apnea test, pre-oxygenate and disconnect from ventilator. Pre-oxygenate the patient and disconnect the ventilator. Positive test, no spontaneous respiration for 8 to 10 minutes, no spontaneous respiration for 8 to 10 minutes with a PaCO2 is more than with a PaCO2 is more than 60 millimeter of mercury and arterial pH is less than 7.28. So PaCO2 is 60 and pH is less than 7.28. If it is positive, it meets the local requirement, meets the local requirement. Yes, it is brain death. If these criteria does not all prerequisite present but high suspicion of brain death, do the EEG, absence of intracranial blood flow. If there is absence of intracranial blood flow on CT angiogram or MR angiogram or carotid arteriography positive, you can consider this patient as a brain death. On neurological examination, difficult to evaluate or patient is paralyzed, yes. If the patient is difficult to evaluate and patient is paralyzed, then do EEG and CT angiogram. In if apnea test, if difficult to interpret or inconclusive, then again do the EEG or CT angiogram or MR angiogram. If there is absence of intracranial blood flow, think about brain death. Additional test can be confirmed brain death is cerebral blood flow study like CT angiography, and brain death constitutes of and clinical death, legal or clinical death, and mechanical ventilation may be withdrawn with the patients, or mechanical ventilation may be withdrawn without the family's permission. Okay, if we look at this, that bring the case to the hospital ethics committee. When there is difference of opinion between the family and the medical team over life-sustaining measures in a patient with established brain death, the American Medical Association principles of medical ethics committee recommend seeking consultation from an independent, objective medium like ethics committee. However, note that this is medically appropriate to discontinue therapy after brain death. Technically, the physician does not need to obtain the family's permission to remove life support. Nevertheless, recommendation mostly advocate an empathetic approach which meets the family's emotional needs and try to reach the mutual understanding. Can a patient be diagnosed with brain death? They have an intact deep tendon reflex? Yes, deep tendon reflex may be intact. Brain death is characterized by absent cortical and brainstem function, but the spinal cord may be functioning. Brain death means absent cortical and brainstem function, but spinal cord may be functioning. And there is another term called persistent vegetative state. Is similar is similar to person having consciousness but lack awareness. Diagnosed after 12 months. Diagnosed after 12 months. Okay, now I would like to discuss a thing that what is the neurologic outcomes of coma? What is the neurologic outcomes of coma? What does it mean? Not awake and aware. Not awake and aware. That means acute coma. So not awake and aware. That means acute coma. It may be due to severe brain injury, anoxic or traumatic brain injury, or variable brainstem reflex. Okay, if the patient is awake and aware, double A. If the patient is awake and aware, then recovery can happen. The three outcome of this coma can happen. Recovery can happen. May have residual cognitive, motor, or sensory deficit. If there is awake and aware, recovery can happen. And from acute coma, brain death can happen. In acute coma, brain death can happen. So how can we diagnose the brain death? Brain death is diagnosed first do the brainstem reflex. Brainstem reflex. If no brainstem reflex, then do the apnea test. If apnea test positive, no brainstem reflex, think about brain death. Remove the ventilator. Okay. If it is awake but not aware, awake but not aware, it means persistent vegetative state. The last thing, persistent vegetative state means formally diagnosed after sufficient time has elapsed since brain injury. In anoxic brain injury, more than 3 months. In traumatic brain injury, more than 12 months. So anoxic brain injury, anoxia more than 3 months, and traumatic more than 12 months, indicating minimal probability of recovery. If the patient is on anoxia, you can wait for 3 months for returning of the patient. If it does not happen, so it is persistent vegetative state, so this patient might not have recovered. Okay, in persistent vegetative state, brainstem reflex usually intact. The difference between brain death and persistent vegetative state is brainstem reflex usually intact. There is no apnea, no purposeful interaction with the environment, no purposeful interaction with the environment. So that is all about brain death. It's a very simple topic, but it is complex when you are dealing with this type of patient. Okay, if we look at this question, this 19-year-old, this is one of the NBME question. A 19-year-old admitted to the hospital after sustaining head trauma. So traumatic. GCS is very low, 3. Okay, intubated mechanically. Okay, there is mm, 24 hour of the admission. His temperature is 100, pulse okay, BP low, pupils are fixed and dilated with no corneal reflex, no brainstem reflex, no brainstem reflex. He does not respond to the painful stimuli, no gag response. Another brainstem reflex, no gag, no corneal response. He does not respond to any sort of painful stimuli. What is the most appropriate next step in the management of no brainstem? Do the apnea test. So do the apnea test, and what you will find in the, how will you confirm the apnea test? If positive apnea test means no respiration and PaCO2 is more than 60 millimeter of mercury. So PaOC2 is 60 millimeter of mercury. So do the apnea test. If apnea test is positive, then you can tell the patient that he is brain dead and you can remove the ventilator. That's all for today.